Welcome to this video on psychotic disorders, part of the Department of Psychiatry's Basic Science lecture series. We will cover the foundations of clinical psychiatry necessary for your studies. In this video, we will define psychosis, classify major psychotic disorders, explore the epidemiology and etiology of schizophrenia, identify key symptoms, and discuss the clinical approach and the impact of stigma. Psychosis is a clinical syndrome characterized by a state of impaired contact with reality. Core features include delusions, hallucinations, disorganized thinking or speech, and abnormal motor behavior. It may be a primary psychiatric condition or secondary to other factors. It is important to distinguish between normal and psychotic mental states. In a normal state, perceptions and thoughts are logical and reality-based, while in a psychotic state, there are hallucinations, fixed delusions, disorganized behavior, and often reduced insight. Our understanding of psychosis has evolved significantly, from Krappelin's dementia praecox in 1893 and Bleuler's coining of schizophrenia to the discovery of antipsychotic medications in the 1950s. Today, it is viewed as a complex, multifactorial neurobiological syndrome. Epidemiologically, schizophrenia affects about 24 million people worldwide. Its prevalence is fairly consistent across cultures, with a typical onset in early adulthood. Notably, it is associated with a significantly higher mortality rate compared to the general population. Classification systems help standardize diagnosis. This video references the DSM-5-TR and ICD-11, both of which include categories such as schizophrenia, schizoaffective disorder, delusional disorder, and various secondary psychotic syndromes. The spectrum of psychotic disorders is often viewed by the duration of symptoms, ranging from brief psychotic disorder to chronic conditions like schizophrenia. All these disorders share the core feature of impaired reality testing. We will now focus on schizophrenia, often considered the prototypical psychotic disorder. Schizophrenia is a severe, chronic disorder marked by disturbances in thinking, perception, and emotion. It causes significant functional impairment and is a leading cause of disability-adjusted life years among young adults globally. The epidemiology of schizophrenia includes a global prevalence of 0.3 to 0.7%. Environmental factors like urban residence and migration are linked to higher risk, and patients face a reduced life expectancy, often due to physical health comorbidities and suicide. Genetics play a major role in etiology, with high heritability. The risk increases substantially with genetic relatedness, as seen in twin studies. While the disorder is polygenic, rare genetic variants can also contribute to individual risk. The neurodevelopmental hypothesis suggests that schizophrenia arises from disrupted brain development occurring well before symptoms appear. Prenatal insults and childhood developmental delays may precede the onset of full illness, which often coincides with synaptic pruning during adolescence. The dopamine hypothesis maps symptoms to 4 distinct pathways. For example, increased activity in the mesolimbic pathway is linked to positive symptoms, while activity in other pathways relates to cognitive and negative symptoms or side effects of medications. Finally, the glutamate or NMDA hypothesis proposes that hypofunction of NMDA receptors is a core abnormality. This helps explain the limitations of current dopamine-blocking treatments and provides a target for developing new therapies. Neuroimaging studies have provided valuable insights into the pathophysiology of schizophrenia. Common findings include enlarged lateral and third ventricles, indicating a loss of brain tissue, alongside reductions in total brain and gray matter volume in areas like the prefrontal cortex and medial temporal lobe. Further neuroimaging observations show reduced thalamic volume and cortical thinning that may progress over time. Functional imaging has also demonstrated prefrontal hypofrontality during cognitive tasks. It is important to note that these are group-level trends, and no single brain scan can diagnose an individual patient. Risk factors for schizophrenia are multifactorial. Biological and genetic risks include a family history of psychosis, prenatal issues like infection or malnutrition, obstetric complications, advanced paternal age, and heavy cannabis use during adolescence. Psychosocial and environmental factors also contribute significantly. These include being raised in an urban environment, the stress of migration, history of childhood trauma or abuse, low socioeconomic status, and high levels of expressed emotion within the family environment. We will now transition to the clinical features of schizophrenia, specifically how we recognize the symptoms of psychosis. Positive symptoms refer to an excess or distortion of normal function. Essentially, experiences that are added to the normal state. These include delusions, hallucinations, disorganized speech, and grossly disorganized motor behavior, including catatonia. These symptoms generally show a good response to antipsychotic medication. Delusions are fixed, false beliefs that are not shared by one's culture and persist despite evidence to the contrary. Common types include persecutory, grandiose, referential, somatic, and erotomanic delusions. Bizarre delusions, such as the belief that thoughts are being withdrawn or that one is being controlled, are particularly characteristic of schizophrenia. Hallucinations are perception-like experiences occurring without an external stimulus. Auditory hallucinations are the most common in schizophrenia. Other forms, such as visual, olfactory, gustatory, or tactile hallucinations, may point toward other organic or substance-related causes and should be distinguished from illusions or pseudo-hallucinations. Formal thought disorders manifest as disorganized speech. This includes loosening of associations, tangentiality, the use of neologisms, clanging, or word salad. Poverty of speech, which is a reduction in the amount or content of speech, may also occur and overlaps with negative symptom domains. Disorganized or abnormal motor behavior ranges from agitation to purposeless, non-goal-directed activities. It may also include difficulties with self-care. Catatonic features, such as stupor, waxy flexibility, or echolalia, require explicit screening as they can be associated with various psychiatric and medical conditions. Negative symptoms represent a loss or diminution of normal function, often described by the quote, 5 A's: affect, alogia, anhedonia, asociality, and avolition. Unlike positive symptoms, these often persist between episodes and are generally more challenging to treat. Cognitive symptoms often precede the emergence of psychosis and persist throughout the illness. They include impairments in working memory, attention, executive function, and social cognition. These deficits are strong predictors of long-term functional and occupational outcomes for the patient. To summarize, the clinical presentation of schizophrenia is defined by the interplay of positive, negative, and cognitive symptom domains. The DSM-5-TR diagnostic criteria for schizophrenia require at least 2 core symptoms, such as delusions, hallucinations, or disorganized speech, present for a significant portion of 1 month. A diagnosis also requires a marked functional decline, a total duration of at least 6 months, and the exclusion of other medical or substance-induced causes. The course of illness is categorized into 4 phases: premorbid, prodromal, active or acute, and residual. Early identification during the prodromal phase is crucial, as it allows for earlier intervention, which is linked to better long-term functional outcomes. We will now discuss other psychotic disorders, beginning with schizoaffective disorder. This diagnosis requires an uninterrupted period of illness with a major mood episode, either depressive or manic, concurrent with schizophrenia-like symptoms. Notably, hallucinations or delusions must be present for at least 2 weeks without prominent mood symptoms, while mood symptoms remain present for the majority of the total illness. Brief psychotic disorder is characterized by the sudden onset of at least 1 positive psychotic symptom, lasting between 1 day and 1 month, with a full return to prior functioning. It can occur with or without an identifiable stressor. If it occurs within 4 weeks of delivery, it is classified as postpartum onset. Delusional disorder is defined by the presence of at least 1 delusion for a month or longer, without meeting the full criteria for schizophrenia. Beyond the impact of the delusion, behavior is generally not bizarre, and functioning is relatively preserved. Onset typically occurs in middle or late adulthood. Delusional disorder can be categorized into various subtypes based on the delusional theme, such as persecutory, jealous, erotomanic, somatic, or grandiose, reflecting the diverse ways this disorder can manifest in patients. Shared psychotic disorder, historically known as folie à deux, involves a secondary person adopting the delusion of a primary individual with whom they share a close relationship. Typically occurring in socially isolated dyads, this condition often resolves upon separation. In the DSM-5-TR, it is now coded as an other specified psychotic disorder. Substance or medication-induced psychotic disorder involves symptoms that develop during or soon after substance use or withdrawal. Common triggers include stimulants, cannabis, and corticosteroids. Symptoms should exceed what is expected for the substance itself and usually resolve within weeks of abstinence. Persistence may suggest an underlying primary psychiatric condition. A psychotic disorder due to another medical condition is diagnosed when hallucinations or delusions are the direct pathophysiological result of an underlying illness, such as epilepsy, endocrine disease, or autoimmune conditions like encephalitis. Red flags for an organic cause include late age of onset, abnormal vitals, or focal neurological findings. Catatonia is a psychomotor syndrome, not a standalone disorder, marked by features such as stupor, mutism, or waxy flexibility. A diagnosis requires at least 3 of 12 specific features. It can occur across various psychotic, mood, and medical conditions, with benzodiazepines serving as the primary treatment of choice. When evaluating these disorders, clinicians compare them based on duration, symptom profiles, the presence of mood episodes, and the exclusion of medical or substance-related causes to ensure an accurate diagnosis. Moving to assessment, we will explore the differential diagnosis and the investigative process, which are essential for determining the correct clinical path. The differential diagnosis of psychosis is split between primary psychiatric conditions, such as schizophrenia or mood disorders, and secondary or organic causes. The latter include delirium, substance effects, and various neurological or metabolic diseases that must be ruled out. The mental status examination is a cornerstone of the assessment. Clinicians observe appearance, behavior, and speech while evaluating thought process and content. It is vital to assess perception, specifically inquiring about hallucinations, and gauge the patient's insight and judgment to determine risk and decision-making capacity. Effective history-taking focuses on the onset and course of symptoms. Because patients may have limited insight, obtaining a collateral history from family or friends is essential. Clinicians must also screen for substance use, family psychiatric history, and conduct a thorough risk assessment for suicide and violence. While schizophrenia is a clinical diagnosis without a single lab test, investigations are critical to exclude organic causes. This includes a full blood count, metabolic and thyroid panels, and toxicology screening. For first episodes or atypical presentations, further workup may be required. Finally, regarding neuroimaging, an MRI is preferred for evaluating potential structural lesions. While routine imaging is not required for typical, established cases, it is indicated for first episode psychosis or cases with focal signs. Other tests, such as an EEG or lumbar puncture, are reserved for suspected neurological or autoimmune conditions.